The third one of the papers we wanted to discuss today is the one by Simone and Romano. Senior author is Afshin Farzani, and I welcome them also today to join us here. And it's called Feature Tracking Global Longitudinal Strain Predicts Death in a Multicenter Population of Patients with Ischemic and Non-Ischemic Dilated Cardiomyopathy, Incremental to Ejection Fraction and Late Gadolinium Enhancement. So sort of similar to the others. So the first paper was more on the ischemic side, and showed they all showed that longitudinal stress can help. So this this paper was looking at both ischemic and non-ischemic cardiomyopathy. So these were 4 centers in the United States. The coordinating center was the University of Illinois in Chicago. And they looked at a total of more than 1,000 patients with an ejection fraction of less than 50% and ischemic or non-ischemic cardiomyopathy. Only, and this is really remarkable, only 35 of these patients had to be excluded because of uninterpretable image quality, and that's of course something again you cannot have with any other imaging modality in looking at LV function. So I thought that this is remarkable. They performed a standard protocol with scanners from 3 different vendors, both at 1.5 and 3 Tesla, which should not be a limitation when we look at cine imaging. Late gadolinium enhancement was also performed and was scored visually using a 17-segment model. And here is a figure showing examples of the strain in 2, 3, and 4 chamber view. So the results, the mean age of the population was about 60. The mean ejection fraction was 34% roughly, and the global longitudinal stress was decreased. So these are all really not that surprising findings. About half of them were ischemic, about half of them were non-ischemic. The details you can find here, also the baseline characteristics, here stratified by the tertiles of the global longitudinal stress. And here you see already a couple of significances, but they do not really, it's clear that there will be group differences, but that's not the point. The point is, the key question is, what's the prognostic value? Now, first of all, in terms of the variability, it's important to check for that always, and all the papers we discussed today did that. And here in this particular one, there was a very good agreement between readers and also within readers. So that's also, when you look at strain imaging, that's always very important. So what did they find? So when they divided that into tertiles, and maybe I'll just jump into this figure, looking at the global longitudinal stress, they found that when they used these cutoff values of -8.7 and -13, that these tertiles had a very strong prognostic implication on the survival. And it's important to realize that this is all-cause mortality. That's important. Lots of paper going either by MACE or by cardiovascular death, but this may be problematic. MACE, you can call whatever you have, and cardiovascular death may sometimes be difficult, may overestimate or underestimate the real. So, of course, overall death is by many considered a very strong endpoint, and that's what they did. And of course, with a follow-up of more than 5 years, that's what you can do, because your event rate, even using all-cause mortality, will be high enough to draw meaningful conclusions. So what they saw here, that the global longitudinal stress clearly could identify survival or predict survival. And if you look at the numbers, so having, and this is overall for the entire population, so having a global longitudinal stress of less than -13, then gives you an excellent prognosis. whereas here, if you have values like 8.7 or worse, then the survival is less than 70%. So about 2/3 will survive, and about 1/3 will not. So I think this is pretty huge. And if we go into a little bit more detail and stratify that further, according to the ejection fraction, that kind of echoes the finding we had from Ingo's and Thomas' paper, which we discussed before, that those with a reduced, severely reduced ejection fraction of 35%, and a highly abnormal longitudinal stress, they had the worst prognosis with a survival rate of just 50%. So there was always an additional discriminative value of the longitudinal stress, again, above and beyond the ejection fraction. So here you can see the presence of late gadolinium enhancement, yes or no. That is a known prognosticator, but you see here the separation of the curves is not the same as it is the longitudinal stress. And here also presence or absence of late gadolinium enhancement, the global longitudinal stress still adds something, although it is not as impressive as it is for the ejection fraction. And that is actually true for both the ischemic here on the left side and the non-ischemic cardiomyopathy. So the bottom line of this paper, and here are the statistics, so the multivariate analysis actually confirmed that in ischemic cardiomyopathy, longitudinal stress was really the only independent strong marker surviving the multivariable model. Whereas in non-ischemic cardiomyopathy, late gadolinium enhancement presence still was predictive, although with a lower hazard ratio and a somewhat weaker p-value. So the bottom line here is, again, global longitudinal stress seems to have a very strong prognostic impact in patients with ischemic cardiomyopathy. After MI, the Leipzig paper had just a fairly short follow-up, so they had to go for MACE. And the Guevara paper was not sure whether there would be an added value on top of other markers. Now, this comparison was not done here, but to me, these papers indicate that longitudinal stress apparently adds to what we can extract from images, from CMR images, goes beyond what ejection fraction alone can offer, goes beyond what that gadolinium enhancement alone can offer. So I think it is certainly a marker which should be considered in clinical decision-making. Now I would be extremely interested in the opinion of Chandra. I'm very proud and happy to welcome you here to our CMR Journal Club. Chandra is the editor-in-chief of JACC Imaging and doing an outstanding job in this position. And he, together with Chris Kramer and Raymond Kwong, wrote an editorial on that. So, Chandra, looking at all that, do you think we're at a point where we should perform global longitudinal stress as a kind of a routine in patients? And I don't know whether you're...
Thanks, Matthias.
Hi.
Yeah, can you hear me?
Yes, yeah, we can hear you.
Yeah. Oh, hi, good morning. Thank you for inviting me. This is great. So, and thank you for bringing some JACC imaging papers. So the question we had is, we got these 3 papers around the same time, and I'm glad we could put it in one issue. It's exciting technology, but some of these are the first papers in this area, right? So we got to be a little careful on what this technology means in the long term, right? So the echo literature has shown GLS is predictive in pretty much everything, right? Whatever condition you take, it's predictive. What we don't know is why it's predictive, right? We believe it's a contractile property, deformation imaging, and that's what we are picking up, more subtle changes than EF alone. And that's that's the reason why it's predictive, but we don't know that for sure. What the beauty of feature tracking was that we don't have the image limitations that echo has. You need very good images on echo to get good GLS data. So CMR can have advantage on that, but it's important to remember that they are tracking two different things, right? So in echo, we are tracking speckles which are inside the myocardium, whereas CMR is a little different. It's tracking boundaries, right?
Mm-hmm.
And so, so these were exciting to us. What was really the reason why we got excited here was that if you remember the echo papers, they are uniformly positive, but they don't adjust for infarct size very precisely. They don't certainly adjust for LGE and MVO. And so it's easy to show a difference in echo literature, whereas in CMR literature, when you're setting the bar so high, it's tough to show a difference. And the fact that you can show a difference even over MVO and LGE is something remarkable. So that was what really drove our decision making. Some of our colleagues said, the echo colleagues said, we've already shown this in echo, what's new? You're just using a new tool to show it, but there is additional value. And so that's the attractive part. What we are looking for in future papers is showing that different methods have same standardized outputs. For example, in the two papers, the Gavara paper and the ITIL paper, the methods were different. And so there's no standardization here. That will be one thing that needs to come up. And second, we need to show a continuous variable difference, not just a convenient cutoff. I mean, we can always pull off a cutoff, say GLS over 8 or 9 or 11 or 13, and say it predicts. But what ultimately we need is a continuous plot that GLS down below, say 18, 19 or something has an incremental prognostic value across the spectrum. So those are the papers we think would be very great. And I look forward to your comments.
Thank you very much, Chandra, for that view. And I agree. So we certainly have to make sure there are several technical approaches to evaluate strain, and we have to figure out there are some papers comparing them, but we have to be probably make sure that they are really showing the same thing. We have to work on cutoff values. So concerning the question, why do we think the longitudinal stress? I would just throw out a hypothesis. So longitudinal strain, so to me, is a marker of overall compliance of the left ventricle. And to me, a factor that may be interesting in that context is that myocardial edema, even if it's global as a problem in all sorts of diseases, for example, caused by high end diastolic pressure, where the perfusion pressure has to compete with that. So even mild edema could induce a stiffness, and there are some good papers showing that and drawing that connection. So to me, it could be that whatever the initial injury is, if the ventricle has reached this point where it gets stiff and non-compliant, that is when it's going downhill, and that's why the longitudinal stress maybe. But this is just a wild hypothesis, and maybe some of you who are in research could address that. So I wanted to ask also, give Afshin, he's the senior author of the Multicenter trial by Romano and co-workers, a chance. So what is your view? Because your paper was, say, particularly strong in terms of showing a very strong difference between those with a sort of decreased and significantly decreased longitudinal stress. So what is your takeaway on that in terms of eventual clinical application? Afshin, I think you're muted on. If you're...
Hi, Matthias. Thank you. Can you hear me now?
Yeah, we can hear you now. Great.
Yeah, thank you very much. I agree very much with Dr. Chandrasekhar about the issue of variability with different, because all three of these papers basically use different methods to do the feature tracking, different software, and they're all kind of black boxes, and we don't really know exactly how each of these vendors measures feature tracking precisely. So there's a lot of issues, just like in echo, that have to be resolved. And I think we're quite a way off using it for in clinical practice yet, I think, because of those issues. And there are also other technical issues as well. One other thing I wanted to bring up was I think that there's also some interesting work being done about simpler methods of assessing the longitudinal function of the heart, particularly related to movement of the mitral valve plane and MAPC. And, you know, I think there's some evidence that a lot of the information that we get from GLS may also be obtainable from those simpler methods. So that's, I think, an area that's interesting going forward also.
Yeah, that's actually a good point. And Marco Ochs, you from Heidelberg, you have published also on MAPC and also on aortic valve. Do you want to comment on that? Do you think it can be used instead of as a placeholder instead of longitudinal strain analysis?
Yeah, in general, I really appreciate strain measurements, and it's a great concept, but it's still difficult to measure it by feature tracking methods or even by special sequences. It's still a problem, and it's consuming a lot of time. And we have some running projects right now where we try to find parameters that are much easier to acquire. And we think that they might have the same prognostic value or even might be better than the global longitudinal strain. And one of them is the movement of the mitral or the aortic valvular plane. We call it the APSE or the MAPSE. And we are really excited about the results which should be coming up in the future, in the near future.
That's great. So I guess that sounds like we have to stay tuned first on the standardization of the longitudinal strain measurements and then potentially easier markers based on valvular plane displacement. So before we have to close, and we're already a little bit over time, there's a question from Jill. She is basically asking, okay, why are you so fussed about the longitudinal strain? What about the radial and circumferential strain? So my take on that would be when they were compared, typically longitudinal strain came out as the stronger marker on that. But I don't know, Thomas, you have used all of them in your study. Do you want to briefly comment on that?
Yeah. Longitudinal strain was pretty much the strongest parameter in our analysis. We also did it with circumferential and radial strain. Circumferential was not so bad as well. We did not have so good experience with radial strain. Reproducibility is not that good. And if you look at other papers, like looking at the different strain values, it's always the longitudinal strain that comes up as the strongest predictor. I don't know why, but it's in all studies. It's a congruent finding in all the analysis. If you look at ischemic cardiomyopathy, non-ischemic cardiomyopathy, it's always the longitudinal.
Yeah, and
Matthias, I have a comment for that. So this is coming very clearly in the cardio-oncology literature. They are different fiber bundles, right? The circumferential strain is more related to the mid-wall fibers, which are circumferential. And they are more dependent on torsion. So it looks like the subendocardial problems, especially in ischemia, or the increased end diastolic pressure, like you were saying, they affect the longitudinal fibers predominantly. And one reason why the EF is preserved when the GLS is reduced is it appears that the circumferential strain is compensating for the decrease and still keeps the EF okay. So that's a very fertile area of investigation.
Well, thank you so much, Chandra. That's a very good comment.
That's a fantastic comment.
Yeah, and from Min Liu comes the comment that longitudinal shortening is the most important factor to ventricular ejection. And this is sort of also echoing what you said. The other factors may also, the other strain directions may also not be that stable and sometimes more affected by regional issues. And then the mid layer, as you said, Chandra, is particularly interesting, I think, especially in the basal value where these mid layers probably are exposed to the most stress, and that's why we have the mid-wall sign as such a bad prognostic marker. Okay, so I think that was fantastic. I think we had, that was a record contribution today with more than 80 participants. So Chandra, thank you very much for joining. Afshin, Marco, Thomas, and for the great discussion, and everybody for participating. Before I let you go, I want to just point to next week's papers. So next week the focus will be on interventional MR, starting with electrophysiology, and we will have from Reza Razavi's group, we will have the authors of this paper on epicardial electroanatomical mapping, ablation lesion imaging in a pig model in real time under real-time MR guidance, and then we will have people from Leipzig. A clinical workflow and applicability of EP ablation during MR, and we'll have Ingo Pech also participating. So the topic next week will be EP. With that, I want to thank you again very much for your participation. I hope to see many of you next week at the same time. And otherwise, I wish you a great day or a good evening wherever you are. Bye-bye, everybody. And bye, Chandra. Thanks so much again.
Yeah, you're welcome. Thank you. Bye.
Bye.
Bye-bye. Thank you very much.
Pleasure.